I'd like to invite, it's a great honor for us to have Professor Mahipal Sachdev, sir, who pioneered the initial phase of research and R&D of Elita Silk. He's going to speak about long-term and experience with Elita Silk, a new lenticle extraction machine from Johnson & Johnson.
Thank you, Rohit. It was really nice to be associated with the initial trials with Rohit participating significantly in their group. I'll be talking about this new technology, which is the lenticule-based technology, which is now commercially available in majority of the parts of the world. US, still some FDA data is coming out. Now, the Elita femtosecond laser started as a cheetah project because cheetah is the fastest animal on earth. And therefore, because they prided themselves with the fastest laser as regards the rep rate, and that was why it was called as the cheetah. But now they have named it as the Elita femtosecond laser, doing the procedure which is called as smooth incision lenticular keratomelusis. The normal thing that has been agreed is called as KLEX, so, but this is Silk is the name that is there. Now, when you look at the Elita system, there are a couple of advantages or a couple of things that have happened. It is obviously a flapless procedure to create a lenticule which is there, so it's a blade-free, flap-free procedure. The biggest advantage here is that it is the shortest, it is the smallest spot that is available. I'll be just discussing, which releases low energy treatment. As things stand today, it releases about 30% less energy as compared to, say, a Visumax system. But today, what Dr. Jeevan Tatyal just mentioned in his talk is that the spot and the track separation can be done, because when we were doing it was basically a study, it was an FDA monitored study also, and you cannot make these variations. And because you could not make these variations, therefore we have still to do a spot separation. As things stand today, each spot hits after the other spot. So it's a 1.2 or a 1.4 micron spot, and there is no spot separation or no line separation. Animal studies have been done which has reduced, just by increasing the spot separation by 2 microns, the energy has been further reduced by 48%. So that is something which is very important. We are pushing the company because it needs a little hardware updation, and hopefully in the next quarter we should be able to work and play around with the spot separation. That is going to make this still better. So what we are going to have is the allergy coming down further, ultra short pulse duration, ultra fast pulse frequency, and a very small focus size. So that is something important. Now what it does is that it creates fast and smooth cuts which are almost bridge free. That means that you can actually need zero or no dissection or minimal dissection to take out the lenticule. There have been very few or no instances of retained lenticule that has been reported with this particular technology. So what it does is to cause minimal tissue disruption in the stroma. So that's the part of the engineering of the laser. Now let us just look at what it is. The biggest difference here is that it is a biconvex lenticule. If you look at the other lenticules, they are plano-convex lenticules. So this is a biconvex lenticule, and Rohit and his group has elegantly shown that the amount of spherical abrasion or higher order abrasions is the least. Though there is, we still have to do a head-to-head study, but the quality of vision is supposedly better than the other lenticule procedures. So this is what broadly one has to say. The other thing that he has shown is that basically, because when you come like here, if there is a plano-convex lenticule like this, it will cut at this point. So nerves are going to get cut a little earlier, because when you are a biconvex, the nerves keep coming like this, and therefore they don't get cut at this particular level, which would get cut in a plano-convex lenticule. So therefore, the amount of dry eye that is being caused is supposedly lesser than the other lenticule procedures. As it is in lenticule procedures, you get less amount of dry eye as compared to the flap procedures which is there. So if you look at the pulse duration, this is only 100 to 200 femtosecond as compared to the intralace, those who had used the intralace, which is 600 to 800 femtoseconds. The pulse frequency, as you can see, has gone up significantly from 150 kilohertz to megahertz. So that's 10 megahertz, which is there. Spot size has been reduced from 3 microns to 1.3 microns. Those who have been using Visumax know that it is 4 micron. So this is a very small spot size. Wavelengths obviously are the same. So this is, if you look at the pulse duration which is there. This is just a comparison that the pulse energy is the lowest, which is only about 50 to 70 nanojoules with zero spot separation. And this is the high intensity small beam which hits at a given time. Comparison between Visumax 500, IFS and Elita, as you can see in these particular slides here, you can see that this is how it comes. So it is a low energy laser pulse which creates tissue bridge free lenticules that are easy to separate and remove. Just a small representation that Raghav, who's worked with us tirelessly, you need to cut up paper, you make holes like a postage stamp, and you have holes which are next to each other. You have small holes and you have large holes, so you will see that there will be areas which would be making it a little more difficult for you to so just to make you understand that if you have smaller spot size and you have no spot separation, the separation would be much easier. So this is, as we are looking at, it is called as silk or smooth incision lenticular keratomelusis. What we used was, what it is commercially available is that it can be done between -1 diopter to -12, and this is with the conversion and the add-on. So and the cylinder, even if you have a pure cylinder, you can go up to -6 cylindrical correction. The time taken is about 16 to 17 seconds for a treatment time, and as you know, this is the biggest advantage when you are doing a lenticular procedure, that whether you are doing 1 diopters or you are doing 10 diopters, the time taken would be the same because it is cutting but at different planes, as compared to an excimer which has to burn more in 10 diopter as compared to the 1 diopter. The other important thing which is there right from the beginning, which was a problem with the Visumax 500, now I think that has been taken care of with the Pro, but it is that post-docking centration and cyclotorsion adjustments were not possible there. But in this particular case, right from day one, though manual at the present moment, but you can do post-docking centration and cyclotorsion adjustment. So these are the systems, these are the 5 systems that are available today on the market. Okay, obviously there are 2 systems of the Visumax 500 and the Visumax Pro. Pro is a faster laser, and you can see you have the Zemer, you have the ATOS, and you have the Elita. So this is the comparison which is there. So you can see pretty much that the pulse repetition rate, this is the Zemer and the Elita are the fastest lasers which are there. Energy per pulse, you can see this is got the lowest pulse energy which is there. Time taken, Visumax 800, I think Sonu is here, he is using it. Visumax 800 has the shortest treatment time just now as compared to the others. The patient interface is flat in 2 lasers, and that is the Zemer system and the Elita system, while it is curved in the other systems which is there. Cyclotorsion compensation, except for the Visumax 500, all have cyclotorsion compensation and centration. Again, all the machines that have come in new have centration and cyclotorsion adjustments that are there. This just to show you, it's a 2-piece patient interface. Again, the next round of development is to get a single-piece patient interface. You can see this is a 2-piece. This is the suction that is applied. The suction comes from the machine. You have to manually mark. You can see these are the marks that is there. You can mark the center also if you are worried about the angles. And then you can go in and you have this machine on the green part. So this arrow has to be somewhere around 30, 40, 50, whatever you want in the green. The applanation has to be outside this 10 millimeter, and you can see I am doing a centration adjustment and a cyclotorsion adjustment. So you can do a centration and a cyclotorsion adjustment which is there, and then the machine says this is a 3-degree adjustment, as you can see there, which has happened. And then you have the foot switch. You could see it was 16 point some seconds, and this is the undersurface of the lenticule. This is the round side cut which is there. This is the top cut of the lenticule. lenticule, and then you have the entry cut, which in this particular eye it is 3 millimeters, but you can do from 2 millimeters to 5 millimeters. You can alter the position of the entry cut, whether you want it at 12 o'clock or you want it sideways temporally, whatever, you can do it, and that's the end of the procedure which is there. Now, the important thing the important thing here is that the patient interface ensures easy docking and proper suction. So these are the two parts of the patient interface. This goes below on the undersurface of the machine, and you can see this is what goes on. This goes again on the machine for giving you a suction which is controlled. The pressure which often people ask is about 50 millimeters of mercury when you are having. So it's a tight suction. Yes, it gives you more pressure, but has no effect on the vasculature of the retina. But what is important is that the incidence of suction loss are almost eliminated, or very minimal, if at all, that is there. Flat applanation for precise laser. So what they feel, the company feels, is that because the applanation is flat, you can get a better profile, and that is why you can get a biconvex lenticule. There is the auto Z calibration which compensates for the thickness and tilt. So for every PI that you put on the eye, there is a calibration that happens beforehand. So if there is a tilt or there is a thickness change, that will reject the PI, and therefore you will not work on it. So you can center the lenticule on the visual axis. Just a simple ask the patient to look, and you can center the patient on the lenticule. So that is the visual axis. Marking, I told you, this is this is just a OCT. We were doing it as part of the trial. Microscope doesn't come inbuilt with the machine, so you can use any microscope that you want for this. You can see this is the anterior plane, this is the posterior plane that you can see we are going in, and the OCT here is going to show you where exactly you are going in. I'll just do fast forward to show you the ease. It is going, there is especially in the anterior plane. In the posterior plane, they hold up at the 3 and 9 because it does not allow the lenticule to like posterior. Again, you can see very little or no dissection. Again, the 3 and 9 o'clock where there is a little, but again, effort. You can just pull out the lenticule. As you can see, it's easy to pull out the lenticule. That is the completion of the. This is, I'll just skip this. So patient selection target with -6 and up to -2, these were the initial cases. So first we did phase 1, phase 2, phase 3 study. Phase 1 was on amblyopic eyes, and in amblyopic eyes we were looking at less than -6 correction up to -2, compliant, easygoing, 18 years plus, etc., non-pregnant. Patients should not have any other contraindication. So this was the first phase of the study design. We started it, and Dr. Rohit team contributed. So it was a 2-site study, and proud to say that both the sites were in India, as you can see. In this, it was a single arm, 170 treated eyes. Main endpoints was mean pre-op and post-op MRSC, uncorrected, best expected, and lenticule created in both eyes using the ELITA system which is there. So the study results, as you can see, that the surgeons rated the ease of lenticule removal as no or mild dissection needed in 85% of the cases. This is one hallmark. Uncorrected visual acuity of 20/20 or better. The 12-month follow-up is slightly limited, but in the limited number of cases that we have, 100% of the patients achieves 20/20. Within plus minus 0.5 was 91% at 6 months follow-up, and the subjects were slightly undercorrected. So like there has been a nomogram adjustment in the Visumax which people do, there have been 2 sets of nomogram adjustment in this this machine also. One set which was purely a spherical nomogram, so you overcorrected, like with, you add minus 0.25 and you add 5% of the refractive error, so that's what you did. But as you went, the cylinder also we have overcorrected. So this you can see is the result, as you can see that the whole thing is getting compressed as it is. The ease of lenticule removal, 91% of cases required little or no dissection and 86% is mild dissection, as you can see. Clear corneas on day one, really patients are biomicroscopically fantastic on this thing. This is the publication in Clinical Ophthalmology which has been published as the study results of this for the correction of myopia. One important thing, I don't think, Rohit, you aren't making any presentation.
No.
So this is again, Rohit's group has shown that the Chinese have shown that there are micro distortions in the Bowman layer after lenticular surgery, which leads to slower recovery of vision and abrasions. But what has been seen by his group is that on confocal, and on OCT, anterior segment OCT, because of the biconvex shape, and if you smoothen it out, the micro distortions in the Bowmans are much lower in the silk procedure as otherwise. And this is a total of our center as other centers. You can see that the induction of higher order abrasions is minimalistic in this particular procedure which is there. This is again to show you the point spread version. Obviously you can see a fantastic point spreads function that is there. So friends, this is just a run through the study which the first ELITA procedure was done in January 2020. So it's 4 years of 3 to 4 years of work which is there, and my personal impression is that it lives up to the name silk, minor or no tissue adhesion, no complete lenticule removal in all cases, none of the cases that any difficulty with the entry cut. The entry cut, it goes over it about 8 times. So it goes very easily. It's like you're going with a warm knife through butter. Fast visual recovery, accurate refractive correction, specifically after the first and the second nomogram adjustment, tight outcomes and tight standard deviation, and the patient satisfaction is very great. So this is what I wanted to tell before you as regards this particular thing. Obviously you need to do a good centration, approach the identifying anterior plane, but it doesn't matter. Even if you go in the posterior, you can still take out the anterior. There is no problem. The nose, because of the patient interface, and the cheek, you need to just tilt the head so that there isn't any kind of discomfort or difficulty in doing the applanation, and proper instrumentations are required. So this is the machine that is commercially available. I think there are about 5 or 6 systems or 7. I don't know. Every day the count goes on increasing in India today. And overall, I think there are about 30 systems that are there. Also, just to tell you that it has 2 capabilities just now. The first capability is that it makes a flap, and the second is the lenticule. As of now, it does not do keratoplasties, and as of now, it does not do the rings. So these are 2 things that will obviously come on. So thank you very much for your kind attention. Thank you.
Thank you, Professor Mahipal, sir, for a very nicely covered